deformity. Yes, hinge is a very easy option, very easy to do, and less surgical load on surgeon's mind. But as this is a young patient, 32, 33, though there are some medical problems with him, if a patient who is there without a medical problem and at 32 just with hemophilia, perhaps hinge would be a bit too much, because then we would not have anything else after 10 years. So perhaps as principle, it is an excellent demonstration of what can be done so as to reduce the load of the next surgical step. That is step 1, to reduce the load of step 2, and step 2 obviously, then step 3 helps step 2, so that we get the full correction. So that's a comment I wanted to make.
Another one comment I want to make is, I don't know, Subranju, how much of fracture rate you had, but every MUA you do post-op, you need to fracture rate has to be high. And you're now, for this case, I think at least in our private setup, 50 lakhs would be the budget.
That's true.
That is true. In private setup, probably you get away with doing a hinge and at one step, go ahead with
One step surgery.
But this is a public hospital case, so we have to have constraints also. And one important that we get our factor free, anti-hemophilic factor. Otherwise, it requires a lot of anti-hemophilic factor. So that we get free from the society, hemophilic society.
In MUA, you need to have fracture rate to be optimal. You cannot do MUA without optimum fracture rate levels.
No, that you get when you do a single surgery, then you get optimum factor rate. But here, multiple manipulation, during each manipulation, we need to administer factor. Then during the soft tissue release, we needed factor. Then post-op manipulations also, at each step we need factor, to be given to the patient. So those things are, has to be taken into account. You should have a good laboratory backup to assess the factors, etc. So we are not discussing the hemophilia part. We are discussing about, the orthopedics part about it. Thank you.
I have one question to Dr. Mohanty. Normally, you talk about the TC3 as a varus valgus constraint if you have a little bit of mediolateral this thing. So what amount of flexion extension mismatch would you be able to correct with a TC3 type of design without causing flexion instability post-op?
No, see, this is a case, it doesn't have any varus valgus, constraint here. In this case, especially it was a flexion extension, and we are going to even PS knee. If the flexion deformity would have been less, but only because it was osteoporosis that I had to use stem extenders also, because it will require manipulations. And when there is a flexion extension mismatch, then post in the insert. The post which is longer, that helps to prevent certain mid-flexion instability.
Just let me answer a specific answer. The jump height of the implant depends on the depth of a box and height your post of the tibia. If the difference between the flexion extension gap is less than the jump height of your implant, the implant will be okay. When a huge difference is there between a flexion gap, and if the jump height, which is in a normal constant design, is roughly about 15 to 17 millimeter. If the discrepancy is more than that, then you need a hinge.
Harish, you have brought in a very pertinent point, which I wanted to bring if we had time in relation to
we'll discuss it later. Let's go ahead with the
Manoj's. Exactly. The jump of height is specific to different implant design. For example, the TC3 has a 8 millimeter tolerance to the jump of height. Anyway, we'll come to it if we have time.
Manoj, can you go ahead with your lecture?
Yeah, thanks, Harish. I think before I start, I have a question from educating myself from the first 4 speakers, because all of them showed a PCL sacrifice. Now, the basic thing I understand about any fixed flexion deformity is you have a mismatch between flexion extension gap. That means you have a good flexion gap and a very narrow extension gap. Now, on top of it, you cut the PCL, which adds up another 3 to 4 millimeter to the flexion gap. So now you have even a bigger variance of a mismatch of flexion extension gap, especially in FFD where the PCL is also stretched out. So can somebody just first educate me why we need to cut the PCL?
Previous 4 speakers, any takers?
Manoj,
say that you're not a speaker. Sir, in a fixed flexion deformity, you have a flexion extension mismatch.
Yes.
Your extension gap is smaller than the flexion gap.
Yes.
On top of it, when flexion gap is already higher, you want to cut the PCL, which will jack up the flexion gap another 3 to 4 millimeters. So you have a bigger variance. Now for matching it up, you want to cut the distal femur because you want to match extension to the flexion. But what is the science behind it? I just don't understand. So first, I would like to get education from my previous speakers, because all four of them showed a PS knee correction.
Anybody?
Yeah, can I take that question? Yeah,
Yeah, please.
Yeah, so I would agree with Manoj. So this is a doubt I had in my mind. So the cases in flexion deformity where you cannot get full extension without elevating the joint line, that is when the PCL becomes secondarily tight. So you have to release the PCL. So all the previous speakers showed a 4 millimeter additional distal femoral cut. If you don't need to do an additional distal femoral cut to balance your knee, you're able to balance, then you're perfectly all right doing a cruciate retaining knee. But some deformity more than 30,
so
you will require additional cut.
Krishna, not understand, it's not a knee which is ankylosed in extension. It's a knee which is in flexion. So PCL is already stretched. You already have a stretch of PCL available with you, increased length of PCL with you. You already have a joint line maintained. You just need to work onto the extension gap, and why are we jacking up the flexion gap? So anyways, I know that I'm
not able to correct the deformity.
Manoj, you yourself are saying, see, in most of these severe FFD in inflammatory pathologies, just as your collaterals have been stretched out, similarly, your PCL, the collagen of your PCL is heavily compromised as a result of this chronic synovitic inflammatory.
It's a feel. I'm sorry to say, it's just a feel. So, anyways, I think let me run it through. I know that I'm going to swim against the flow.
We will take your call after the presentation.
Yeah. So basically, I have always understood one thing: this retaining or substituting a PCL, whatever we say, is either a philosophy that you believe in or it's a training that you follow through. But either of the two things, I'm going to show you all the same deformities that you mentioned through, one in OA, one in RA, and the same thing can be done by retaining the PCL. In almost 95% of my flexion deformities, be it flexion alone or varus or a valgus, I think in our hands, we can get it off with these. So in a Lombardi grade 1, 2, and 3 that we saw through even severe contractures, PCL retention can be done in all these cases, I would say 95% of the times. Yes, you always need to have a back off of a higher level of constraint with you. So first case I'm going to show you is 62-year-old male gentleman, bilateral knee flexion, around 20 degrees of varus, and fixed flexion deformity of ranging 30-35 degree, range of motion from 30 to 80. So this is the AP and the lateral view you look at out here. You have a typical V with the osteophytes on the medial side, on the front, in the intercondylar notch, into the back of the femur and back of the tibia. So hip, knee, ankle axis is obliterated. You have a fixed flexion deformity around 30. The video of the patient will show us all these things. So this is a typical picture of complex deformity, where one would say, okay, the PCL is compromised. Now, the first thing is, as Bharat now answer to what you said, a PCL does not have to be histologically normal. You take off the osteophytes, intercondylar notch, you still have a well-functioning PCL at the back of it. So the pathological elements that we need to address in all these things is A, osteophytes in the front, which cause a mechanical block and lack of extension. Osteophytes at the back of the tibia and the femur. On top of it, the posterior capsule, which is becoming shrunk up and synced up. In very severe cases, as Dr. Mohanty said, hamstring and gastroc get involved, but mainly it's to play with the capsular retraction and the posterior curtain, which is because of the osteophytes at the back of the femur and the tibia. So you expose it like a normal knee, do osteophytectomy. The additional bone on the medial side of the tibia is chipped off with the nibbler. You go ahead, take off the intercondylar osteophytes, restore the protesis. Here at this stage, you, as Dr. Victor said, you take a long elevator, release the capsule from the back of the tibia. The PCL is still intact. Here, I would suggest use a trial prosthesis of femur. Use a curved osteotome on top of it, take out the trial, and then take the posterior osteophytes from the back of the femur. The posterior osteophytes are taken off, calcium elevation is done. You preserve the PCL. What you have to release is the posteromedial and the lateral corners. You also have to take off these notch osteophytes, which tent the PCL, and osteophytes at the back of the PCL need to be taken out. Like a typical CR knee, you first do the polo test. Pull-out test, if it is light and relaxed, that means you have to jack up the polyethylene. If the PCL is tight, like they say in the left picture, you only have to release the bundle, the anterolateral bundle out here. If the knee is PCL is totally tight, which is very, very rare in these kind of FFD cases, you go on the back of the tibia and release the tibial attachment. But normally it is not required. What you just need is a small recession of PCL on the anterolateral side, and you have an appropriately tensioned femoral component. And you can very easily reach these kind of pictures. In this OA knee, what I want to summarize is when you want to do a CR correction of the OA knee, understand the philosophy. And the philosophy is you do a relaxation with anesthesia that improves, remove the osteophytes, posterior clearance and posterior recession. And now in these cases, handling the PCL is very, very important. Avoid stiffness by a tight PCL and do not ever overleave the PCL to cause a flexion instability. There you would need a higher level of constraint and aim for full correction at surgery. In an OA knee, normally I would not like to leave a resident of 10 to 15 degrees of FFB. We would like to achieve it in totality. Now, going from this onward, this is a rheumatoid. Like you see this kid, 17-year-old girl with this rheumatoid. Here in this case, as you're talking about what we do before, I did a needling and a casting for 2 times. So now at this stage, she had 60 to 70 degrees of flexion contractures. So some sort of release was done percutaneously. And on top of it, she was taken in for surgery. So from 60, after doing the release and after doing the anesthesia, giving the anesthesia, we dropped down to 40. This is the kind of picture that you have in these cases, and the chicken drumstick appearance at the back we will discuss out here. These are the pictures that you see across. So in all cases which are severe fixed flexion deformity in rheumatoid with bone and ligament changes in the 17-year-old girl, I would never like to reduce any bone. I would like to salvage as much bone as possible so that ever if she requires a revision, as Dr. Mohanty said, it's possible for me to jump from a CR to a PS as the next stage. So posterior condylar bone loss is there, and the consideration for this chicken drumstick appearance is the sizing of the femur. You don't want to undersize the femur because that will increase the flexion gap even further. So in those cases, you take the right sides and the apicondylar axis and flexion space balancing. Never use posterior referencing. You should be beware of posterior referencing in these kind of systems because they will put you to a wrong kind of a sizing and rotation of the femoral component. So sequential is the same. You do a posterior release from the tibia, take a standard 9 mm cut. If you are very tight in extension that you see like this, in a CR knee, never take more than 2 mm because you want to retain the joint line as much as possible and you want to retain the patellofemoral function. So in this case, we took 2 mm only, no 4, no 6 in a CR knee, only 2 mm. So if this is not sufficient, we go back in and do the posterior capsulectomy. So on the medial side, the lateral side, we can't raise the curtain because we have a PCL in the center, use laminar spreaders on each side. Go very gradual with electrocautery. The moment you got the capsule, you see a yellow fatty tissue at the back and stop at that stage. On the medial side, on the lateral side, and what you get is a correction reaching to around 10 degrees of remnanting. In a rheumatoid, they stretch out subsequently. So from 60 with percussion and cast, we went on to 40. With anesthesia, again 10 degrees, 30 degrees we covered up during surgery and left with 10 degrees across as swing. And this was, we use an oxynium implant, as you see out here, CR knee. So considering she's very young, this is the same kid dancing across with all the patients. So all those things get gradually covered up. What I just want to bring across is the different ways of going and reaching to the same parameter. So you can do the PCL, but you can also retain the PCL. If you're using it regularly and you know how to play with the posterior cruciate ligament, there is no need to release it. This is what the point I was giving through. You should maintain the joint line at a proper level. Never leave the PCL too tight. Utilize Polo test. Assess and release posterior impingement, because in an OA knee, you need to work on the osteophytes. In a rheumatoid knee, you need to work on the soft tissue structures. What you need to prevent is any residual flexion contracture. So the points that I'm going to summarize out here are very, very important. Whenever you do these cases, in a normal CR knee that I would do, I would keep 5 to 7 degrees of posterior slope. Here I would underslope. I would keep around 3 degrees of slope only because I do not want to have a residual flexion contractures. Also, a very bad variant is if you are not particular in tear referencing and you put your femoral component in flexion. So be very particular in your final implantation. You're not going to put a femoral component in flexion because these two points, if not worked well on table, will give you a residual flexion contracture. So in a rheumatoid, even if you leave those knees in 10 to 15 degrees of persistent thing, with time they all stretch on, reach to normal. So this is a different way of floating around the same kind of complex knees, retaining the PCL and not adding to the amount of constraint that you go through. With this, any questions that you have, I'm more than happy to answer.
Manoj, wonderful presentation. And I think you may be